And we left off on the spleen. So spleen, blunt abdominal trauma causes splenic injuries. Why is the spleen so vulnerable? One, because it's, depending on how much your rib cage covers it, it can be exposed. But the second thing is it's got a long vascular pedicle, right? It's the splenic artery's got to go a long way. So stuff that jostles your abdomen around can tag the splenic artery. You'll get shock, left upper quadrant pain, Kerr's sign. The diagnosis, it's a solid organ, so CT. Treatment, non-operative management for grade 1, grade 2. And then remember to give them their vaccines. I have the pneumococcal and the HIB vaccine, but now it's meningitis B vaccine as well. So 3 vaccines. The question they might ask about a non-vaccinated splenic loss is overwhelming post-splenectomy sepsis. I've seen this twice in my career. It's very frightening. People who weren't vaccinated for their pneumococcal vaccine after having a spleen out, they get a pneumococcal pneumonia and they'll die right in front of you. Now, the spleen is vulnerable because of the long splenic artery in its position, but the liver is the most common injured in penetrating trauma. I already said that before because it's the largest unless you're pregnant. Pancreatic and small intestine injuries. These are sneaky because they can be CT negative. They can happen in blunt trauma. The one they love is the handlebar injury. So if you have a bicycle and you spin the handlebar in the air, like the kids like to do when they're doing their tricks, and you land with the handlebar in this thing, the front wheel will not roll. Now you'll go ass over tea kettle, but the handlebar will be like a javelin. So you'll see a circular abrasion on the abdomen where the handlebar goes in. It's often going in right in the sort of epigastric region. So that puts duodenum and spleen at risk. Remember, if the second and third segment of the duodenum are injured, that's so close to the liver, they almost always have a liver injury. But you can have isolated injuries of both the pancreas and the spleen in these situations. They may ask you about lipase. How sensitive is a lipase at looking for this? Not good. So CT is the best, but it still misses some. And again, if they have persistent pain, CT negative, that mechanism, you want to get a surgical consult. They probably ought to be admitted and observed. Small intestine injuries, I already talked about lap belt injury patterns, which gives classic bucket handle tear where the mesentery is ripped off the small intestine, either in the superior mesenteric artery distribution, more often, and less common in the inferior mesenteric artery distribution. So, stomach, duodenum, and bowel injuries, much more common in penetrating trauma. It always blows my mind that you can get shot in the abdomen. Bullet goes in here, comes out there. 10% of the time, it hits nothing. Like, that just doesn't seem like it should be right. But then you sort of remember a little bit about ballistics. As the bullet enters the skin, it deforms the skin breaks, and those sort of concussive waves of force go in front, precede the bullet, and stuff that can move will. It's like your kidneys will be like, bullet come through, get out of the way. And your intestines will too, and that's why in third trimester of pregnancy, where things are packed in, they can't move. So a stab injury or a gunshot wound are more likely to tag things because they don't have the mobility. As I mentioned, most duodenal injuries have a liver injury as well. We talked about the bihandlebar, which could be duodenum or spleen. And bowel injuries can have delayed symptoms, which is why if they're CT negative with a lap belt, you're going to admit them because you're worried about that. All right, now we talk about GU trauma. There's often questions about this. It's very examinal because you want to talk about both the general things. You need to know, obviously, blood at the meatus, no Foley. Boggy prostate and perineal bruising makes you worry. And the diagnostic test to do when they have blood at the meatus or gross hematuria in front of you, you don't want to place a Foley, so you're going to do a retrograde urethrogram, a RUG. We're going to talk about anterior and posterior. These come in 2 different sort of patterns, and they're summarized nicely here. The anterior urethral injuries are the straddle injuries, plus minus a fractured penis. Some of these are iatrogenic. I worked at LA County for years. We have a jail service there. You always see these troubled young men coming in from jail that proudly proclaim they have 17 coffee stir sticks and a paperclip in their urethra. You're like, great. And so what's going to happen with these anterior urethral injuries that are that way or other things is they're at risk for, obviously, urethral injuries. They should be primarily repaired when they're found. And the complications are fistula and stricture. Compare that to the posterior ones, which is a fractured pelvis, major car accident, which comes in with a distended bladder, lower abdominal plane. They might have a scrotal hematoma, and their complications, in addition to bleeding to death with a pelvic injury, particularly if it has posterior components to it, their GU complications are impotence and incontinence, quite different from the anterior urethral injuries, lends itself to questioning. Here you see the hash marks over the yellow indicates urine. So this is an anterior urethral injury because it's anterior to the urogenital diaphragm, and the urine comes out. It's usually sterile. It creates a urinoma, and that urinoma can be in the scrotum. It can be around the penis. It can be into the anterior thighs because the bladder is not intra-abdominal. The bladder is a preperitoneal structure, and so when you have an anterior urethral injury, the urine comes out in those areas. The first time you see a one of these anterior urethral injuries with a thin sheen of urine around the penis, you'll look at it, you'll be like, boy, what is that? And that's what it is. I've seen that a couple of times. I remember I was a resident. This guy came in after some pelvic fractures that were managed conservatively. He had a big thigh swelling. I was like, what is that? And it wasn't red, it wasn't warm. So I listened to it. It wasn't pulsatile. I stuck a needle in it and urine came out. And I was like, holy Jesus, how did I hit his bladder? I was looking back at where the hole was. I was like, there's no way I hit his bladder. And I just wasn't familiar that you could get a urinoma in the anterior thigh from an anterior urethral injury. And that's just what that's showing there. Here's what happens with a posterior urethral injury above the urogenital diaphragm. You get blood tracking around. Notice, urine tracking anterior to the bladder. Notice that urine is not free in the abdominal cavity. So the FAST exam would be negative for free fluid, but you might see collection of fluid around the bladder that's anterior. Again, the bladder in an adult has a preperitoneal position, largely. That's a little different from children. This is one of the differences about kids. A kid who has a distended bladder and has blunt abdominal trauma, if that bladder ruptured, that urine might go free in the abdominal cavity. So you could have urine free masquerading as blood, because remember, the ultrasound doesn't tell you the difference, just says there's free fluid, it doesn't tell you what the fluid is. So pediatric bladder ruptures can be intra-abdominal, but in adults, both posterior urethral injuries and bladder ruptures are usually not intra-abdominal, they're pre-peritoneal. Here's, I suppose that could be a penis, but there's a lot of blood around, and so you can't put a Foley in, so they're going to do a retrograde urethrogram. So there's the catheter right in the tip, and they inject it. Oh, everything looks good here. Dye going in, urethra looks good. Oh, and then it goes all over the place, and that's a posterior urethral injury with some pelvic fractures. You can see that pelvis doesn't look like it's architecturally normal, and that's there are questions about what's the indication for a retrograde urethrogram. If they can't have a Foley placed, you might do suprapubic cystostomy, Seldinger's technique. You should use an ultrasound to guide yourself into a full bladder. And there are some of the indications. You need drainage, but you can't pass it. Trauma with blood at the meatus. Urethral strictures that can't be passed. Transection of the urethra with an anterior urethral injury or GU burns. And there's the contraindications. Nope, pregnancy is not a contraindication, but you still would like to be ultrasound guided so you don't misplace it. Testicular trauma, real common in blunt and straddle injury. The problem is they come in with this big bruised scrotum that you really can't examine. What you want to know is a testicle fractured? Because testicular broken in half, they will put them back together again. They revascularize pretty nicely. So emergent repair of a testicle is indicated. And so what you need to do is get a better image of that testicle, and the way to do so is an ultrasound, or if you have a urologist who will do it, they can do direct exploration. It's my experience that they're woefully hesitant to do direct exploration, no matter what you're asking them for. And so they're usually going to want you to image that up. It's a bad day when your scrotal hematoma eats your penis, as this is. And you can imagine that examining that, this looks like he's a day out maybe from it. This is a typical bar injury, right? Most bar fights should start with a kick to the balls. That's the honorable first thing to do in a bar fight if you can't avoid it. Is the first noise should be while you look for the exit. Renal trauma, often asked about, and it's just sort of unfair. You would think that if someone has a renal injury, they should have hematuria. Like, throw me a bone. And it turns out that a quarter of them don't. Right? If you have a complete renovascular injury, you're not perfusing their kidney, so you're not going to make urine, so there's going to be no blood in it. And so that's unfortunate. Many of them do, but if they have gross hematuria, That's now the criteria to work up the GU tract. Many of you remember the days we worked them up for 5 red cells per high power, then 50, then 100, and it kept going up until we said gross hematuria. And now we know that gross hematuria gets you either an IVP, no one does that anymore, or a contrast CT urogram. That's what's done. So that's the answer nowadays. If you're worried about renal injuries, is a CT urogram. And if you time that right and do enough dye load, you can look for ureteral injuries as well. If they have a renal pedicle injury, which is less than 1% of all renal injuries, then you might want to revascularize them. You might be able to fix that renal pedicle injury and revascularize that kidney and save it. Now, it is the weirdest thing because everywhere else in the body, when you got to revascularize something, you got a number of hours, 3, 4 kind of thing. Suddenly here, it's like you got 12 hours. And the reason for that is that the kidney has dual perfusion. In addition to the renal artery perfusing it and making urine and all that, there's almost always a branch artery coming off the adrenals that provides a little bit of circulation to the rim of the kidney. That rim of the kidney is really important because that's where all the nephrons are, and they're the highest oxygen utilizing things. So you may see a devascularized kidney where they do a contrast CT where the renal artery injury and a hematoma there, but there'll be a little blush of contrast in a rim around the kidney. It's called the rim sign. And that's the blood coming from that little adrenal artery, making that kidney revascularizable for up to 12 hours. Now, many kidneys with that kind of injury pattern are not revascularized, and the reason is because they have so many other associated injuries that there are other priorities that take precedence. But if asked about it, yes, you can revascularize kidneys for some time. Also, the kidney, part of the reason it's the center of the transplant world is kidneys are relatively resistant to hypoxia, right? So that's why we harvest and transplant. They were the first organ that we went after that way. Ureter injury is often due to penetrating trauma, very rarely due to blunt, and it's a CT urogram. Bladder injuries, pelvic fractures, I already talked about that. You're looking for gross hematuria, and they may have a urinoma forming, and you want to do a retrograde urethrogram. And then bladder we talked about as well. Some stuff about lacerations, cosmesis, and infection are the major things you want to deal with. You'd like it to look good and not be infected. Infection rates are around 5%, but they vary depending on where. If it's the shin and a diabetic who's overweight, that infection rate might be 15%. Right? So you got to pay attention to the specifics of the laceration for its risk. Initially, most lacerations have low bacterial counts, and the best way to keep them from getting infected is wound prep before repair. And the best part about wound prep is high volume irrigation, not high pressure irrigation. People for a while were using dental picks to irrigate. That actually pushes the bacteria deeper in. So you don't want to use a water pick. You want to use enough force to wash the wound clean, and you might do a mix of blunt debridement and irrigation as well. Delayed healing down there, diabetes, obesity, malnutrition, renal failure, all those things, steroids, chemo. What they're often asking for in questions with that, you got a bad-looking wound, maybe they presented too late. What should you do? Delayed primary closure. We get criticized in the emergency room for sometimes closing wounds we shouldn't have. So if you see a question where there's like lots of reasons not to do it, what they're asking you about is delayed primary closure. Stuff about tetanus. Tdap, the vaccination to prevent you from, you get a series of 5, right, to begin with for tetanus while you're a kid growing up. And then later on, every 10 years, you get a Tdap or a TD. We give a lot of unnecessary tetanus vaccinations. So we give too much of that. People don't usually need it, but we update them anyway. The good news is nowadays there's some pertussis in there. The pertussis wanes a lot faster. If you got your full primary series of 5 tetanus shots, you're probably covered to your mid-50s. We don't do that. We update them. Now, in terms of the pertussis, that wanes every about 5 years. The thing we get bashed on, and that there are sometimes questions on the exam, is you see a Mexican immigrant with a wound, and you say, when was your last tetanus shot? And they look at you like, I don't know if I got any shots. Right? So the unvaccinated immigrant needs what? When you give a tetanus shot to somebody, that protects them for the next wound, right? Not for the current wound. When you see an unvaccinated person, they need protection for the current wound, and that means they get tetanus immune globulin, 250 IU, TIG. What are high-risk wounds for tetanus? Burns, old wounds, soil in the wounds, rust, the rusty farm equipment wounds. How do they present? Usually they present with the, rigidity or stuck smile, the rhesus sardonicus. The United States has about 60 cases of tetanus a year, and 10 to 15 of those are at LA County. I've actually seen a lot of tetanus. They almost all presented with a stiff mouth where a nurse thinks it's dystonia. They ask you for some Benadryl, and it doesn't work, so they ask you for some more Benadryl, and you're like, well, what meds is he on? And you go up there, and he's on no meds. And it's an unvaccinated immigrant with acute tetanus with rhesus sardonicus. Neonatal tetanus, pretty rare to ask questions about that. 3 to 10 days after birth, poor prognosis. Turns out all birth wounds, whether it's the umbilicus or in the mom, are high risk for tetanus. So if you look around the world, if you were going to go to India or Africa where babies are born at home on the floor of a hut, those wounds are high-risk tetanus, and the other high-risk tetanus wounds are burns around the world. But we don't see very much tetanus in the United States, less than 60 cases a year. Clean minor wounds, decontaminate them. There's some things. If they have less than 3 prior immunizations, you're going to give Tdap. All other wounds, less than 3 prior immunizations, they get TIG. The amide and the ester questions. I remember the first time I saw these as a resident, I'm like, what am I, the PDR? I'm really supposed to have memorized the chemical structures of these goddamn local anesthetics to know which one I can. Are you ridiculous? That was my thoughts. You may not share the same hostility I have towards the examiners, but that was my thought. But there's actually an easy way to do it. If the word has 2 I's in it, like lidocaine, it's an amide. And if they were allergic to the amide, you could give an ester, like procaine, that has 1 I in it. So the 2 I anesthetics are amides, the 1 I's are the esters. Also, you could give dilute Benadryl. They sometimes ask about that. You can't use full-strength Benadryl, but if you dilute the Benadryl to a quarter or a third. Anyone tried that? I actually tried it on myself once to see how well it worked. I was pretty impressed with how well it works. Works pretty well. Now, they ask questions about lidocaine or local anesthetic systemic toxicity. So if you give too much lidocaine, and it's not that hard to do, you're injecting a bunch of wounds, road rash, suddenly you realize you've given too much. They might have seizures, they might get agitation, but so you need to know the maximums, and the numbers are there: 4 to 4.5 per kilo without epi, and 7 per kilo with for lidocaine. That comes up. Here it is on this chart as well. 4 and 7 are the numbers I remember for lidocaine. Clipping is preferable to shaving because sometimes things don't grow back. Eyebrows are notorious for not growing back. I remember I was 5 years old. I was going to school for the first time. My mother decided I looked like a filthy long-haired kid, which I did. And so she held me down in this WWE event at the house and shaved my head. And in the process, while she was shaving my head to give me that cleanly shorn, ready for school look, in the struggle, she shaved off my right eyebrow. So I had to go to school for the first day ever, shaved with a bright white head that wasn't suntanned. Ears that are the size of radar sticking out from the earth, as my cousins used to call me, with 1 eyebrow. It was not a good day. I came home all scuffed up. My mother was like, "What happened?" I'm like, "Really?" Anyway, so don't shave eyebrows. Fortunately, this eyebrow grew back. Pressure irrigation is good, but not high pressure. Normal saline tap water effective. Remember, you don't want full-strength Benadryl or providone iodine or full-strength chlorhexidine in the wound because it's cytotoxic, so you like to dilute that if you're using it, but plain irrigation is better. The golden period for primary closure varies by wound site, but the more peripheral it is, hands, feet, shins, you want to close them sooner. Again, we're getting back to this, it's a 24-hour-old shin wound in a diabetic who's been on steroids recently for something. What should you do? Delayed primary closure. Don't close that. It's going to get infected. When should you give a wound antibiotics? And we generally give them too much. That's sort of the universal thinking on the topic. But you should give it for high-risk sites, hands and feet. You should give it for contaminated wounds, puncture wounds, crush wounds, animal bites. Through and through mouth lacerations, open fractures, exposed joints and tendons are all reasons. Prosthetic valves have recently fallen off that if it's a relatively clean wound, and then immunocompromised people. Jan already talked a little bit about some infections and gonorrhea and stuff with periphery, but I'll tell you something that if someone had just told me this in medical school, it would have made life so much easier. When do you worry about Pseudomonas? You worry about Pseudomonas if there's rubber or plastic involved, wet rubber or plastic. So if you're a drug abuser with a plastic syringe with a rubber plunger, you get Pseudomonas. If you're on a vent in the ICU with plastic tubing and rubber and all that moisture and condensation, you'll get Pseudomonas. If you step on a nail through your nasty rubber and plastic sneaker that's wet with the sweat from your foot, you're going to get Pseudomonas. If you get a cellulitis from being in your hot tub, that's this folliculitis that's diffuse, your hot tub's made of rubber and plastic, it's Pseudomonas. If there's cotton or cloth involved, it will be staph. You leave a tampon in, that's cotton or cloth, for too many days, you're going to get staph. You leave too much packing in the nose, it's going to be staph. If you developed an infection under your cast with that cast wadding, it's going to be staph. Clostridia perfringens produces exotoxin, pain out of proportion. You get this dusky, brawny, woody edema. X-ray might show air, but that's not that sensitive a thing to do. Treatment is high dose penicillin. Some people say Flagyl now in penicillin because the penicillin may potentiate the toxins. Debridement, hyperbaric O2. So you can add Flagyl to that slide down there. Neck fash, there's this L-Rhinic score, laboratory risk indicators for necrotizing fasciitis. It's not very useful. I do the score when I need it to convince surgeons that they might need to take them or watch them. But remember, if they have a high white count and a low sodium, you're worried about neck fash. If there's no good reason for someone to have a sodium of 125 and they got a white count of 20 and this nasty extremity, that's neck fash. Be worried about that. Fluid resuscitation, broad spectrum antibiotics, and the key thing to determine whether they live or die if they have neck fash is how long the delay is to getting them to the operating room. Do not let the surgeons take that consult over the phone and say, I'll watch it. No, you need to come in and see this because, you know, what will they say later when the outcome's bad? Well, if they told me how bad it was, of course I would have taken it to the OR. No, make them come in and see it. Some other trauma trivia, tranexamic acid, it's in the new trauma guidelines for ATLS, right? So you got a bad trauma patient, might be bleeding to death. You're going to activate your massive transfusion protocol. You're going to give a gram of tranexamic acid up front during the less than 3 hour period, and then you're going to get another gram over the next 8 hours. Tranexamic acid is now in, based on Crash True and the Matters trial and all that. Blood bank and transfusion, you're going to give them their own blood if you can, you know, from, for example, an autotransfuser off their chest injuries. But if you're going to give them a massive transfusion protocol, you got to worry about some things like hypothermia and hyperkalemia and things like that. Massive transfusion protocols are mostly 1 to 1 to 1. You want to give more fresh frozen and platelets than you've been giving in the past. Pediatric trauma patients in shock, 20 mil per kg of saline is still the answer, and then 10 per kilo of blood. What kind of bacteria are in these things? Human bite wounds, there's about 40 different kind of bacteria, but the question is often about Eikenella corrodens. And if it's a reptile bite, reptiles are just chickens without feathers, right? Right? Chickens, anything that lays eggs, as do all lizards and snakes and things like that, they have a cloaca. That's where the egg comes and then goes out. The cloaca is basically a salmonella cesspool. Anything that has a cloaca has salmonella. Those little green turtles that they used to sell, you know, they're all legal now because the kid would kiss it, oh, my turtle, Charlie, and then they get salmonella meningitis. And you might wonder how the nose of the turtle gets the anal cloacal pathogens to the nose, but it's the rear claw itches the anus, then the front claw itches that, and then it goes like this. And so all reptiles should be considered to be, you know, covered with salmonella. It's not necessarily Salmonella typhi, it may be Salmonella arizoni or one of the other Salmonella species. That guy on the beach with the iguana, there's always one. You want to pet my iguana? Like, I don't know. Ladies, does that work? Does he get chicks with that? I mean, what is the deal with that? Well, there's always some dude with the iguana and say, no, get the thing away from me. No. Cat and dog bites, Pasteurella multocida, they'll give you the cat bite, and actually, the numbers are that they're more likely to be staph or strep. So how do they make the right answer Pasteurella? They give you a time frame. They were bit by a cat 6 hours ago, and they already have ascending lymphangitis. Staph and strep don't do that. That rapid doubling time and super fast onset of infection, that's Pasteurella multocida. We already talked about the air embolism, cap refill. We talked about, is that right? Am I that fast? Woo!